Honorable Chairperson, respected panelists, discussants, and moderators, and dear learned audience, Assalamu alaikum and a very good afternoon. I'm Dr. Abeeda Tasnim Reza, Associate Consultant, Evercare Hospital, Dhaka. Welcome you all in my presentation, and the title of my presentation is To Do, Not to Do, or When to Do. My patient was a 65-year-old female physician by profession, normotensive, diabetic, and with positive family history, presented with chest discomfort and heaviness for 2 days and diagnosed as a case of acute ST-elevated myocardial infarction anteroseptal MI 2 days back. And with all these symptoms, she was admitted in an outside hospital where she underwent coronary angiography. When we found her in our hospital, her vitals are within normal limit, and cardiovascular system examination revealed no significant findings. Her ECG showed there was Q in V1 to V3 indicating a recent anteroseptal MI. Her echocardiography revealed ejection fraction was 45 to 50%. Her coronary angiogram, the right coronary, showed there was a 95 to 99% lesion in the proximal RCA, which was a dominant artery. And her left system coronary angiogram showed that there is distal narrowing of the left main, along with there is 80 to 90% stenosis in the ostial LAD, along with there is almost 100% occlusion in the proximal to mid LAD. And there was also some narrowing in the ostial L6, about 20 to 30%. So we calculated the syntax score of this patient, and it was 30. And if we look at the bifurcation lesion characteristic, it was Medina 111. So what should be the next step? We gave her both the option of our cabbage or PCI, but the patient party wanted to do for PCI, and so we opted for PCI. First of all, we decided to tackle the right coronary. So first of all, we wired the right coronary artery by a cyan blue wire, and it was pre-dilated by a 2 by 20 millimeter NC balloon at 10 to 12 ATM. A 3 by 38 millimeter drug-eluting stent at 14 to 60 ATM was deployed. And post-dilatation was done by a 3.5 by 10 millimeter NC balloon and 18 ATM. And this is the final scene showing a good flow, TME3 flow, with no slow flow reflow or no dissection. So what should be the bifurcation strategy in this case? How can we treat the left coronary system? So as we all know, the bifurcation treatment strategy, that is, we depending on the likelihood of side branch occlusion, and if it is low, it is better to go for the provisional stenting approach. And the RCTs have shown that the provisional strategy has less all-cause mortality than that of the two stent strategies. So we decided to go for a provisional single stent strategy. This is the left coronary system, and the catheter was engaged, and we wired both the LCX by a cyan blue wire, and the LED wiring was done with a balloon support by a cyan blue wire. Then we pre-dilated the LED by a 1.25 by 10 millimeter and 2 by 20 millimeter balloons successively. Then we deployed a 2.5 by 28 millimeter drug-eluting stent from proximal to mid LAD at 16 ATM. Another stent, 3.5 by 23 millimeter drug-eluting stent from left main to proximal LAD, was deployed, covering the distal stent at 16 ATM. And this is the scene after deployment of the stent. But suddenly, the patient developed chest pain, and we found out that the ostial LCX is pinched, and patient was crashing. So now what to do? So in case of provisional stenting, if there is a compromise of the side branch, what we can do? Then we can, there may be, like first of all, we have to wire the side branch for protection. Then assess the flow. If compromised, then we can rewire the side branch and choose any kind of steps such as culotte, T-stent, reverse crush tap. So we decided to go for a reverse crush technique. So First of all, LCX was rewired, and LCX ballooning was done with a 2.5 by 10 millimeter balloon at 12 ATM. LCX was stented with a 3.5 by 12 millimeter stent at 16 ATM, keeping the balloon of the LED in position, and then the LED balloon was dilated, LCX rewired, and kissing balloon inflation by a 3.5 by 12 and 4 by 10 millimeter at 12 ATM in LCX and LED was done respectively. Pot was done by a 4 by 10 millimeter NC balloon and 40 ATM. And this is the cine. So now we decided to go for an IVA study. Both LED and LCX IVA study showed there is good stent apposition with expansion with no dissection. So this is the final scene with wire and without wire, showing TME3 flow, no reflow, slow flow, or no dissection. So what is our take-home message? Decision regarding single versus double stent strategy should be individualized based on lesion characteristics. If side branch is compromised, prompt decision to a bailout strategy is mandatory. And IVAS-guided bifurcation PCI should be used whenever possible, and proper planning is the key to a satisfactory result. Thank you all. Thank you for your patient hearing.